In a right hand dominant person, most likely post-traumatic, most likely due to supracondylar fracture, 3 year old, 3 year old, 3 years back.
Status of the supracondylar fracture?
Malunited supra.
Why you are telling is a cubitus varus deformity?
Cubitus varus deformity. Sir, on inspection, there is inward angulation of the arm with respect to the forearm axis. On inspection.
Inspection cannot tell the angulation. Angulation cannot be seen with result. Inspection.
Deformity.
Inspection. When the patient stands in anatomical position, forearm is deviated towards the midline. It is possible inspection. Then, if the patient fulfills, then only you can measure the angulation. What are the conditions to be fulfilled for measuring the carrying angle?
So there should be no flexion deformity and
precondition for saying there is cubitus varus is that there should be no flexion. That's all. Okay?
So, cubitus varus is supracondylar fracture. Why?
sir, there is a history of traumatic. There is a
No, physical finding.
Finding.
Sir, on inspection, first of all, there is a gunstock deformity present in this patient, and on further inspections,
Why is it called a gunstock deformity?
sir, due to the typical cubitus varus deformity,
Medial
Why
epicondyle.
gunstock?
sir, it resembles the look of a
Medial.
gunstock in which the barrel represents the arm and
Medial epicondyle.
We asked him the exam, many students don't know. It's a typical double barrel gun. That's why it's called a gunstock deformity. Can you see that?
Yes. Rifle. It's a double barrel rifle.
Yeah.
Yes. Then, next point.
sir, on palpation, there is a supracondylar thick region. Supracondylar is thickening. Sir, there is
Which supracondylar is?
some more on the lateral side, middle side.
Middle side is normal.
It appears to be normal.
Appears to be normal. So how can it be supracondylar?
Sir, it is a 3-year-old fracture. It could have been modeled.
What is the magnet? Okay, we'll come in the magnet. Any other points in favor of supracondylar?
Sir, there is increased internal rotation on the.
In favor of supracondylar fracture.
Sir, the 3-point bony relationship is maintained in the patient.
It is maintained.
Sir,
It demonstrates.
actually, the sir, the distance is more or less equal. However, it appears the triangle on the left side is tilted. So there is the inter-epicondylar distance is same. There is minimal distance.
That's the middle epicondyle. That's the lateral epicondyle. That's the olecranon tip. Here, that's the middle epicondyle. That's the lateral epicondyle. That's the olecranon tip. How do you say that the triangle is symmetrical? It is not. You not mark. See that? That's the tip of the. Here. That's the olecranon. See here, and that's your medial epicondyle here. Here, and that's here. That's the lateral epicondyle. Here, that's not where you mark it. This is the lateral epicondyle. Okay, so if you were to measure this distance is more, this distance is less. The triangle is not symmetrical. So the controversy is it equilateral or isosceles? Isosceles means all are same length. Equilateral means two sides are same length. And two are equal. Okay, so that is what it is. So here, whether isosceles or equilateral, the two sides are not symmetrical. Why?
It's irregular triangle.
So it's an irregular triangle. So was there a group contradiction there?
No, sir.
Then how do you explain that?
So the supracondylar fracture is supraphysial. So there is no physial attachment to the supracondylar.
Then how do you explain this? You see the fallacy of the training? When you are marking is wrong. And actually, when you are marking, it is still longer.
Sir, actually the entire epicondylar distance was same on the. It was little bit different, but the lateral limb is longer than the opposite side.
That's why I'm asking.
Yes, sir.
Yeah, what is the problem? Problem is why, how to understand?
Why is the lateral limb longer than the medial limb?
Sir,
That's what I'm asking.
Sir, there is the history is
Is there a growth arrest on the medial side?
No, sir.
Then what is wrong?
Sir, it is a 3-year-old injury,
Yeah.
and with time the tip of the olecranon is being pulled medially with the triceps.
Yes, that's the exact answer. This-
Seat.
So with the limb in varus, the line of pull of the triceps is more medial. So over 3 years, the olecranon comes closer and closer to the medial epicondyle. They described in an article by Dr. Hardas Sandhu in Indian Journal of Orthopaedic, this published paper. Variation in the triangle geometry on the two sides of the supracondylar fractures. Okay, so the medial limb of the triangle becomes shorter because of overgrowth of the olecranon over a period of time. Is it clear?
Yes, another important point. So, how do you know which one is the lateral point?
Sir,
You have to go along this. It is downmost point, downmost and outermost. So, see, we are
Most distal and outer prominent portion.
So that is why, that is the fallacy. Okay, we have told is a malunited. What are the points of factors of malunion which is persistent resulting in this deformity?
Sir, there is a certain displacement in a supracondylar fracture, which is medial tilt, posterior tilt.
In this case, what are the factors which persisted resulting in this deformity?
Sir, there is a posterior tilt which have caused decrease in the flexion. However, there is similar increase in hyperextension in this patient, so the arc of the motion is maintained.
So there is cubitus recurvator.
There is cubitus recurvator.
Show it, show it.
Demonstrate that.
So normal side there is there is little 5 to 10 degrees.
So now you tell what is the statement.
So there is decrease in flexion on the affected side. However, there is
So there is a hyperextension deformity and also the terminal restriction of flexion. So there is a amount of hyperextension is equal to the amount of limitation of the flexion.
Examiner wants to hear the statement that, sir, the range of movement is the same, but the arc of movement is changed. That is what the examiner wants to hear.
Exactly.
He was leading on to that. Okay?
Then the medial tilt, you have told uncorrected medial tilt.
yes, sir. There is increased internal rotation at the shoulder joint.
Rotation is different, tilt is different.
Sir,
No, there is no increase in internal rotation of the shoulder joint.
no, sir.
Shoulder joint range of movement remains the same. Shoulder joint range of movement does not change. What changes?
Arc of arc of motion.
Arc also doesn't change.
Shoulder.
Shoulder, nothing changes. What changes? Nothing changes in the shoulder.
Yes. So there is a deformity in the transverse plane. So there is malunited deformity at the elbow joint.
Okay. Now, when I am doing this, what is my reference limb, which is this? Where is this attached to the distal humerus? And the distal humerus is internally rotated. So when I externally rotate, the normal side will go out more, the affected side will go out less. Can you see this?
Yes, sir.
Going out more. But this is not because of the shoulder. That's because of the reference line has changed. position from the normal to internal rotation. Similarly, if I were to do this will go less and this will go more. Can you see that?
Yes.
And that is the basis of the classical test described, which is described Yamamoto sign.
Yes, sir.
And most students don't know how to demonstrate it. अब इस हाथ को this is the maximum you can take. इस हाथ को ऊपर ले जाओ सीधा. This is classical Yamamoto sign. Can you see that? This is Yamamoto sign, where it demonstrates the increased internal rotation on the side of cubitus varus, because cubitus varus is the combination of three deformities. There is a posterior tilt, there is an internal rotation, and there is
Medial.
medial tilt.
So this is about the rotation. No. So how do you know there is an increased medial tilt?
So there is an increase in supination and decrease in pronation on the affected side, on the left side. And the
Supination pronation is not is a property of the Supra. That is different.
sir, the 3-point bony relationship triangle is tilted.
This triangle is tilted. So how to demonstrate that?
Sir, there are two ways. I have to keep the position, keep both the elbows at the same position. I have examined.
When you are asking a question, don't say there are two ways. In the exam, your adrenaline levels are high, you might forget one. You might, where is the next one now? Examiner may only one way. You said unnecessarily put your foot in mouth and said that there are two ways.
So I keep.
There are 5 causes. You remember only 2. You lose marks. इसको सारा याद नहीं है. देखो इसको सारा याद नहीं है.
So I'll keep both the elbows in the similar position, and then I assess the 3-point bony relationship.
No. The question was, if your triangle is tilted, does it affect your supination pronation?
Yes, sir.
Yes. How does it affect? You have to demonstrate that. This doesn't demonstrate that. Then so what do you expect?
Sir, I am expecting an increase in supination on the affected side.
Increase in supination and decrease in pronation. That is what we expect. करो जरा बाहर को घुमाओ बेटे. Make sure हाँ. See that? And अंदर को घुमाओ. ये वाला घुमाओ.
There is minimal difference in this case.
There is difference. So this is not because of actual. It's the range of movement is the same. The arc of movement is changed because of the tilt of the distal flap. Okay. Cubitus varus is a zero tolerance case. If you don't answer, your chances of failure are very high. Be sure of that.
Okay. So how to manage the case?
Sir, first I would like to quantify. First I would like to get a X-ray of both the elbows in the APU in full extension and both the elbows in 90-degree flexion.
Why 90-degree flexion?
Sir, to look for the for 90-degree flexion in the lateral view. Sir, so that's the true lateral view, and we can assess the radiocapitular relationship in the 90-degree flexion.
You expect the exam not to you. So what is the purpose of doing the radiogram?
Sir, first of all, in the APU, I can assess the deformity, exact deformity by the radiograph, and I
assess
can
the deformity. How to quantify the deformity?
Sir, I can quantify the deformity by making arm and forearm axis on the X-ray and calculating the angle, and which clinically in this case is 28 degree in the varus position and 7 degree which is normal carrying angle. So the deformity would come to 35 degree in this case, and I would like to confirm it on the X-ray.
Okay. So is there an exam?
Right leg.
Any other extent?
In this axis there is a visible posterior tilt as the anterior humeral line is passing anterior to the capitulum.
Okay. Now what will do?
Sir, the patient complains of only deform. The main concern is only cosmetic and there is no functional disability. However, after
Counsel the patient
counseling,
get
even
the
after counseling, the
gar-
parent
garbage.
wants the deformity to be corrected.
Garbage.
Is it only cosmetic or anything?
It is only cosmetic.
So if you leave it, so what will happen? You may danger in future if you leave.
No, sir. Sir, it is only a cosmetic concern.
There are several studies we have shown that if you leave it, it is cosmetic, there is already gone. But there are several instances of development of post-lateral rotatory instability of the elbow. There is recurrent posterior dislocation of the radial head, or there is a fracture. There is a chance of lateral condylar fracture. So instead of knowing all this, we will leave that.
We can operate. We can do a deformity correction in this case.
Now this cosmetic is absolutely obsolete. You have to do something. So
We can do a medial opening where osteotomy or lateral closing as osteotomy. So there is 1 centimeter. Lateral closing as osteotomy, as there is decreased risk of complication in the lateral closing as osteotomy. There is no risk of non-union and
what is that? Which method? Which method will you use? Lateral closage? Primary flange, modified flange. That is the basic things you have to tell. But what is the problem of the modified flange? What is the difference between flange osteotomy and modified flange? What is the advantage, disadvantage of the modified flange? Yes, from the audience? From the audience? Lateral bump formation. Lateral bump, so that is some other osteotomies has already came. Is there any other legal method of osteotomy?
so there is dome osteotomy.
Dome osteotomy. And
Pentagon osteotomy.
so dome osteotomy, that will to obviate this lateral bump formation, the dome osteotomy came. But now again there are some disadvantage of the dome. What is that? In dome osteotomy, dome is like that. So this effect is at the heart. So there is a very little amount of metaphyseal bone for fixation. So in this process of fixation, there is a possibility of fascial damage. So that is how the reverse dome has come. The reverse dome, there is a much more metaphyseal bone segment. So that is better control of the correction, and there is a large amount of bone is preserved for fixation. Okay, at least 2 columns should be fixed like the same principle of supracondylar fracture fixation. Okay. Is there any other?
So in the exam, you may find an examiner who believes in the cosmetic correction part only.
Yes sir.
So you don't have to fight with the examiner.
क्योंकि
You can
हमारा
say
एचडी तो यही बोलता है
it's predominantly
हमारा
a
एचडी तो यही
cosmetic
बोलता है कि
only.
अभी कुछ नहीं करना
However, there are recent
कॉस्मेटिकली
reports
करेक्शन
of
क्या आते हैं घर
increased
बेचना
incidence of fractures of the lateral band, increased incidence of instability of the elbow, posterolateral, increased incidence of fractures of both bones of forearm, and increased incidence of tardial palsy. Even in cubitus varus, tardial palsy is known, not just cubitus valgus. But don't blurt it out as the first complication, because examiner is going to pounce on you the moment you say tardial palsy, but there is literature report on that also. So you can say these reports are there. So weighing the risks and benefits, the parents still want surgery to put in, I would do this surgery. That is how you would go about it. And the surgical procedures, you just heard, there are many varieties, with each one has a problem. But the simplest way to correct the lateral bump is translation. More further your axis of rotation is, your cora is more away from the true axis, more the translation that is required. So if you have a reverse dome, the problem is in reverse dome, the translation required is more. So be prepared for that also. So the examiner might ask you, what is the difference between reverse dome and this? Advantage is there, but disadvantage of translation being more because you are far away from the cora. Now, that is there. So you have to be clear on these things. But the way to prevent the bump is translation.